All right, so before we so I guess let's get started. Colorectal cancer and screenings are not always at the top of everyone's list to share and discuss in a group setting, but we have some really great information for you today. It's easy to understand. I'm sure it will make you a little bit more at ease with the topic, and you get to do it all in the comfort of your own home. It's nice, it's raining outside. Don't have to drive anywhere, so nice to be able to dial in and see this on your computer or other device. So before I hand everything over to Lily, we are going to ask each of you to fill out a really quick poll. I'm going to open that up in a second. It's going to just ask you a couple questions to help us understand your knowledge and your attitudes and your current practice around colorectal cancer. Everything will be anonymous. Just respond as you understand, and we will repeat a similar poll at the end to really understand from our perspective how well we are teaching you and making the presentation worthwhile. So I'm going to go ahead and open that up here in just a second and get to that. All right, it should be open. So go ahead and start answering those questions. Again, everything is anonymous, and make sure as you are completing the questions that you scroll down all the way and click the little button that says submit at the end. Otherwise, we don't receive your responses. Hopefully that has popped up. Okay, I do see some responses coming in now. So again, for those of you who just joined, we have just opened up a poll to help us understand your knowledge about colorectal cancer. We'll repeat a similar poll at the end to help us to understand how well we're presenting the data and make sure that we're teaching it appropriately. So we appreciate your responses in that. We have two finished, one more still going. All right. See, we had one new person join us. So as you signed on, you probably see a poll on your screen. We're doing a pre and post poll for this session. So if you could fill out that poll, there's just a few questions that we need answers to help us gauge everybody's understanding. And then we'll go ahead and get started after you fill that out. Okay, I am going to just go ahead and close that out so that we can move forward. Lily, I will hand it off to you at this point.
Okay, thank you. Good evening, everyone. As Monica said, I'm Lily Jackson. I'm a Cancer Control Strategic Partnerships Manager, Senior Manager for American Cancer Society. I'm sorry, my slides were not advancing. Okay. The content in the slide, okay, I apologize, may not be modified in any manner. This is just our legal documentation that we provide on all of our presentations. So today we're going to talk about colorectal cancer. Sorry, my slides are not advancing. Do you see the full slides on your end, Monica?
I do see them.
Okay.
and see what we'll be talking about.
Okay, thank you. I apologize. But today we'll be talking about how common is colorectal cancer, what is colorectal cancer, the causes, risk factors, signs and symptoms, the prevention, early detection, and just more important information for you to know. Colorectal cancer is the third most leading cause of cancer in men and women in the US. That's not including skin cancer. The American Cancer Society estimated that in 2020, 104,610 new cases of colon cancer will be diagnosed, and 43,340 new cases of rectal cancer will be diagnosed. Colorectal cancer is expected to cause about 53,220 deaths in 2020. Please note that 2021 colorectal cancer data will not be available until 2022. I'm going to go over colorectal cancer basics. The colon is the large bowel or large intestine. It's a muscular tube about 5 feet long. It's part of our digestive system. It absorbs water and salt from food and stores waste matter. After food is chewed and swallowed, it travels through the esophagus to the stomach. There, it is partially broken down and then sent to the small intestine, also known as the small bowel. The small intestines continues breaking down the food and absorbs most of the nutrients. The colon absorbs the remaining water and salt from the food. The waste material that's left after going through the colon is known as feces or stool. It goes into the rectum, and from there it leaves the body through the anus. Colorectal cancer is a term that is used to refer to cancer that develops in the colon or the rectum. These cancers are sometimes referred separately as colon cancer or rectal cancer, depending on where they start. But colon cancer and rectal cancer have many features in common, and we will be discussing those today. Most colorectal cancers start as a growth on the inner lining of the colon or rectum. These growths are called polyps. Some types of polyps can change into cancer over time, usually many years, but not all polyps become cancer. And you'll see abbreviation CRC, and that's in reference to colorectal cancer. The exact cause of colorectal cancer is not known. The most likely cause is related to changes in the genetic material, which we all know is DNA. Inherited gene mutation, those that can pass on to children, these mutations can increase the risk for a small number of colorectal cancers. Inherited mutations affect all the cells in the body. Acquired gene mutation changes, which are changes that take place during a person's life and are not passed on to children. These changes only affect the cells that grow from one cell where the changes began. Most cases of colorectal cancer are caused by these types of changes. When we think about colorectal risk factors, a risk factor is anything that raises your chance of getting a disease such as cancer. Different cancers have different risk factors. Some risk factors like smoking and excess sun exposure can be changed, but others like your age or your family history, they can't be changed. Having a risk factor or even several risk factors does not mean that you will get the disease. And some people who get the disease may not have any known risk factors. Still, researchers have found several risk factors that may increase a person's chance of developing colorectal polyps or colorectal cancer. Some of these cannot be changed, but some can. So when we think about our diet, a diet high in red meat, such as beef, pork, lamb, or liver, and processed meat like hot dogs or lunch meat raises your risk for colorectal cancer. Following a healthy eating pattern that includes plenty of fruit, vegetables, whole grains, and limiting or avoiding red and processed meat and sugary drinks probably lower your risk. Regular physical activity can help lower colorectal cancer. The American Cancer Society recommends that adults exercise 150 to 300 minutes of moderate physical intensity activity weekly. Or you can have a combination of 75 to 150 minutes of vigorous intensity physical activity, and exceeding those minutes also or has been researched to know that it decrease your risk of getting different types of cancer. Being overweight or obese raises the risk of colon or rectal cancer in both men and women. People who have smoked tobacco for a long time are more likely than people who don't smoke to develop or die from colorectal cancer. Colorectal cancer has been linked to moderate to heavy alcohol use. Even light to moderate alcohol use has been associated with some risk. Colorectal cancer risk factors that you can't change. A personal history of colorectal polyp or cancer. Polyps are growths on the inner lining of the colon or rectum. Adenomatous polyps are the kind of polyps that can change into cancer. If you have a family history of adenomatous polyps, you are at an increased risk of developing colorectal cancer. If you've had colorectal cancer, even though it was completely removed, you are more likely to develop new cancer in other parts of the colon and rectum. The chances of this happening are greater if you've had your first colorectal cancer when you were younger. People with a history of colorectal cancer and a first degree relative, which is a parent, sibling, or child, are at an increased risk. The risk is even higher if that relative was diagnosed with cancer when they were younger than 50, or if more than one first degree relative is affected. Having family members who have adenomatous polyps is also linked to a higher risk of colon cancer. Lynch syndrome accounts for about 2 to 4% of all colorectal cancer. These cancers linked to this syndrome tend to develop when people are relatively young. Familial adenomatous polyps also have increased risk for colorectal cancer. Having a personal history of inflammatory bowel disease, including ulcerative colitis or Crohn's disease, your risk of colorectal cancer is increased. If you have irritable bowel disease, you may need to start getting screened for colorectal cancer when you are younger and or be screened more often. Inflammatory bowel disease is different from irritable bowel syndrome, which does not appear to increase your risk for colorectal cancer. Younger adults can get it, but it's still much more common after the age of 50. Your racial and ethnic background, such as being African American and people of the Jewish descent, are a higher risk of colorectal cancer. Having type 2 diabetes and people with type 2 diabetes have an increased risk of colorectal cancer. Now I'm going to talk about your colorectal cancer signs and symptoms. Colorectal cancer may not cause symptoms right away, but if it does, it may cause one of these symptoms. You can have a change in your bowel habits that lasts more than a few days, which may include diarrhea, constipation, narrowing of your stool, feeling that you may need to have a bowel movement, but that feeling never goes away, having rectal bleeding with bright red blood in the stool, which can make the stool look dark brown or black, cramping in the abdominal pain, cramping or abdominal pain, weakness and fatigue, and unattended weight loss. Many of these symptoms can be caused by conditions other than colorectal cancer. So if you have any of these symptoms, it's important to see your doctor right away so that they can find out the cause and have treatment if needed. Colorectal cancer prevention. There's no sure way to prevent colorectal cancer, but there are things that you can do to help lower your risk. Lowering your colorectal risk, get to and stay at a healthy weight. Being overweight or obese increases the risk of colorectal cancer in both men and women. I mentioned before in previous slides that being more active lowers your risk of colorectal cancer and polyps. That's your moderate intensity activities that acquire effort to, such as a brisk walk, dancing, leisure bicycling, ice and roller skating, volleyball, golf, softball, baseball, downhill skiing, mowing the lawn, general yard work, and walking and lifting as a part of a job. Bigger intensity activities are typically activities that engage your large muscle group and causes a noticeable increase in your heart rate. And those activities are jogging, running, circuit activities, weight training, aerobic dancing, martial arts, jumping rope, and trying to limit sedentary behaviors such as sitting down, lying down, watching television, and more screen-based activities. It's recommended that children and adolescents should engage in at least 1 hour of moderate or vigorous intensity activity each day. Lowering your colorectal cancer risk is following a healthy eating pattern. Many studies have found a link between red meat and increased increased colorectal cancer risk. And I mentioned those different red meats in previous slides, and just avoiding or limiting your amount of processed meats, such as bacon, sausage, lunch meats, and hot dogs. It's best not to drink alcohol. People who choose to drink alcohol should limit their consumption to 1 drink per day for women and 2 drinks per day for men. In the United States, the standard drink is equal to 12-ounce beer, an 8-ounce malt liquor, 5 ounces of wine, and 1 ounce of a shot, 80 proof distilled spirit or liquor. For more information, I can share a slide for the CDC in reference to your standard drink. Colorectal cancer and early detection. Early detection means finding and diagnosing a disease earlier than if you had waited for the symptoms to start. Colorectal cancer that's found early when it's small, has not spread is much easier to treat. Colorectal cancer screenings. So your screening is a test used to find cancer or a disease or diseases in people who don't have symptoms. Screenings can help find colorectal cancer when they are small, have not spread, and might be easier to treat. Colorectal screenings can be done with a visual exam or stool-based test. Regular screenings can even prevent colorectal cancer. A polyp can take as many as 10 to 15 years to develop into cancer. Without screenings, with the screenings, doctors can find and remove polyps before they have a chance to turn into cancer. Your stool-based tests are less invasive and easier to have done, but they need to be done more often. Visual tests are done either with the scope and they're put into the rectum, or with a special imaging test. You have to talk to your healthcare provider about the best method that might be right for you. The most important thing is to get tested, no matter which test you choose. The test, these tests for when you're testing the stool, they look for signs that cancer might be present. Since these tests are less invasive and easier to do, they can be done at home. You have your fecal immunochemical test, which is a FIT test, your GAIAC-based fecal occult blood test, and then you have your stool DNA test. If the results from one of these tests is positive for abnormal cells, you will still need a colonoscopy to see if you have cancer. We will talk about colonoscopies in a little bit. A colonoscopy is a thin, lighted, I'm sorry, tube that is put into the anus and passed up into the rectum and the colon to look for abnormal areas. Tissue can be taken from any of the areas of concern, and polyps can be removed if needed. If polyps are found during a colonoscopy, a special instrument can be passed through the colonoscope to remove them. The polyp then can be sent to a lab to be checked under a microscope to see if they have any cells that have changed into cancer. If a tumor or a suspicious area is seen, the doctor can take that sample through the colonoscope. A CT colon graft, unlike a colonoscopy, does not require any type of instrument or a scope to be put into the rectum or the colon. If the polyp or other suspicious areas have been seen in this test, a colonoscopy will still be needed to remove them and to see if to see the area in more detail. American Cancer Society recommendations for the early detection of colorectal cancer. Men and women should start regular screenings at the age of 45. People who are in good health with a life expectancy of more than 10 years should continue regular colorectal screenings through the age of 75. For screening for people who are considered to be of average risk, if they do not have a personal family history of colorectal cancer or a certain type of polyp, a family history of colorectal cancer or polyp, a personal history of inflammatory bowel disease, a confirmed or suspected hereditary colorectal cancer syndrome, or a personal history of getting radiation to the abdomen or pelvic area to treat a prior cancer. For people aged 76 through 85, the decision to be screened should be based on the preference, life expectancy, and overall health or a prior screening history. And people over 85 should no longer get colorectal cancer screenings. So the test options for colorectal cancer screenings are your FIT test, which I mentioned earlier, which they're all stool-based, and your GAIAC fecal occult test, and your multi-targeted stool DNA test. And that's done every 3 years. If a person chooses to be screened with a test other than a colonoscopy, any abnormal test should be followed up with a colonoscopy. There are some differences in the test to consider, but the most important thing is to get screened. No matter which test is chosen, it's important to talk about which test might be a good option for each individual and their insurer about coverage. And as I mentioned before, your visual exams is your colonoscopy, which is done every 10 years, or a CT colonography, every 5 years, and then your flexible sigmoidoscopy, which is done every 5 years. People at high risk for colorectal cancer include those with a family history of colorectal cancer or certain types of polyps, a personal history of colorectal cancer or certain types of polyps, a personal history of inflammatory bowel disease, a known family history of a hereditary colorectal cancer syndrome, and a personal history of radiation to the abdomen. You can get more information on colorectal cancer from the American Cancer Society website, which is cancer.org, or you can call our 24/7 hotline at 1-800-227-2345 to talk to one of our cancer information specialists. And that's the website and phone number. That's all the information I have today. Thank you.
Okay, thank you, Lily. So really quick before we open up the line for questions, I'm going to post that second poll here, which I will open right now. So again, this will help us to understand how well we presented the information so that we can determine how to best present in the future. So everything's anonymous, so go ahead and start answering those polls right now. And don't forget to push submit at the end so that we can record your responses. While you are doing that, I'm going to go ahead and unmute everybody. You should all be unmuted right now. So just know that if there's any background noise, you might want to individually mute yourself or just try to remain quiet so that we can reduce any background noise. Like there's still a couple more in progress on that poll, so I'll leave it open. But if anyone has any questions, you can feel free to chime in right now and ask Lily.
Millie or Lily, how do you get the stool-based test?
Monica, you're offering the stool-based test, correct?
Yes, so that you can either talk to your physicians, but actually I was going to mention this at the end as well. So St. Luke's is actually offering a really great opportunity right now that is completely free to you. At the end of this session, I will actually I'll send a follow-up email to all of you, and you can request a stool-based screening kit to be mailed to you from St. Luke's. And it'll have the instructions and everything in there for you to take the test and return to the St. Luke's lab. Everything's pre-addressed, pre-postage paid, and you'll be able to return that to our lab. We'll cover the cost of processing it, and then getting you back your results, as well as sending them to your primary provider if you want that as well. So thank you for bringing that up. That'll be coming in your email after this session. So if you're interested in that, it's a great opportunity to take advantage of. And as Lily mentioned, if you do get results that have positive results saying that there was blood found in your stool, then there is the extra step required to get a colonoscopy to determine what exactly is causing that blood in your stool. It may be nothing, but that's something that is the follow-up step required for that. So that's an option. You can also talk to your physician.
Okay, thank you.
Yeah. And if you have to, there are different assistant programs where you can get gas cards if you need to come in to receive services at St. Luke's. So if you need to get a test and need to come into the facility, please just make sure that you know that there are services available to reduce barriers.
Is that available through Cancer Society, Lily?
Yes. If you have someone who reaches out to you, we provided some transportation grants to St. Luke, so to just help reduce the barrier of not being able to physically come to your location.
Okay, and you get, and that you get through the cancer.org website?
No, it'll be with St. Luke. So we already provided the transportation grant and they have the services. We just like to help with reducing the barriers. And we know a lot of patients have barriers of just getting to the
Okay.
hospitals for services.
And there's a charge for that?
No charge to you.
Okay.
Any other questions? I'll ask a question. Lily, in case anyone might not be thinking of it, but I think it might be a good question to ask. You mentioned the CT colonography, so that is a less invasive screening option than a colonoscopy. So when might a CT colonography be recommended over colonoscopy?
So all of those are based off of what's provided at your health system as well as what the doctor prefers. But the CT is just more of a way to do an image of the body versus having to be put to sleep for the colonoscopy. It works the same as just to look at specific areas of the body that may have the doctors may have concern for. But a CT versus a colonoscopy, just colonoscopy is more invasive. And then the prep for the colonoscopy sometimes deters people from getting it. But it'll all be what's available and health system and if the physician is offering the CT versus the colonoscopy.
So talking to your physician is
Yes.
course of action. Okay.
And
Are
I
there
think
any
that
other?
sometimes we try to tell people just getting past the prep for a colonoscopy, that's the worst part when you hear people talk about not wanting to get it. It's just to prepare for it. But you are under general anesthesia and you typically don't have any people who have side effects unless there is some side effects with anesthesia. And I don't mind. I had a colonoscopy and I don't remember any of it.
That's great. And you know, when you think of colorectal cancer and being able to actually remove the polyp and prevent the cancer from potentially growing, you know, that's pretty amazing. Not all cancers are the same way. So it's a really amazing technology that we have available to us, and it's worth that discomfort of the prep, whatever else may be. So it's definitely worth it. But it is
And the
great
fact
that
that you
we
can have it at the same time. I'm sorry.
I was going to say it's also great that there are other screening options, you know, available like the stool-based test for those that might be more apprehensive to still get some level of screening.
I agree.
Great. All right, one final request for any questions from the participants. Okay, I'm going to assume that means no. So that's all we have tonight. Thank you all for participating tonight. Thank you, Lily, for presenting. And remember to be on the lookout for that email with the link for your free screening kit. Thank you for choosing St. Luke's, and we hope you have a good evening.
Thank you.
Bye.
Bye. Very good.